everyone to our very first and inaugural episode of TLDR'EM or TLDR'EM. It's for Too Long Don't Read Emergency Medicine. So I'm Aida, your host for today, and we are very lucky today to have two experts in emergency medicine, Dr. Khadijah and Dr. Zul.
Hi, pleasure to be here.
Yeah, okay. So TLDR'EM is our podcast to explore new trends, innovation and challenges in emergent medicine. And for Dr. Khadijah, would you like to introduce yourself briefly?
Hi, I'm Khadijah. I am an emergency physician and lecturer in the University of Malaya. I've been practicing since I think 2014. I do have kind of like an interest in critical care and ultrasound overall. I do have a fellowship in critical care ultrasound as well. And I guess that's it. That's the reason why I chose the topic today, which we'll be discussing a bit more later on.
Thank you, Dr. Khadijah. Okay, now, Dr. Zul, the spotlight is on you now. Can you briefly introduce yourself?
Hi, I'm Dr. Zulkarnain. Okay, I'm also an emergency physician and a senior lecturer in University of Malaya. I have a special interest in some of the critical care stuff. That's why I think the topic will be related to what we're going to discuss today.
Okay, guys, I'm so thrilled to hear topics presented by these two experts. So, today for our first episode, we are going to talk about the two main vessels in our body. So one person will be talking about the vein, and another person will be talking about an artery. Okay, so I think we'll start with Dr. Zul. So Dr. Zul will be talking about the aortic dissection. So Dr. Zul, I would like to know, why have you chosen this topic?
Okay, I think dissection is the quite kind of rare but a catastrophic condition, and most of our residents might have some misdiagnosed, and also they might have a late diagnosis of this that can cause a poor outcome and morbidity and mortality to the patient. So I must say aortic dissection is a great miracle. So later we will discuss what are the pearls and how are we going to diagnose and the principle of management of aortic dissection.
Okay, so Dr. Zul, why do you think it's so challenging to pick up the aortic dissection?
Okay, because when talking about aortic dissection, it involves a big artery like aorta. So it's come from head up down to the toes. So it can present with a usual presentation like chest pain and stroke. However, if we delay in diagnosing the aortic dissection, and in 1 or 2 hours delay, can cause like a higher percentage of mortality. So I think that myself, I will try to simplify, and hopefully we can able to detect the red flags of the aortic dissection.
Yeah, because the aortic dissection is not very common, and the presentation, like pain, and other manifestations are very common in other diseases as well. So it's very hard to, pick
Yep.
up on this. Yeah. So Dr. Zul, would you like to share more detail?
Okay.
What your recommendations and
Yeah, sure. I think the first things I want to highlight will be the 5 pain of pearls. Okay. The number one will be our residents should ask 3 main questions regarding the pain. The first is the quality of the pain. How is the quality of the pain? Okay. Normally the aortic dissection will come with a sharp and tearing pain. All right. And then the intensity on onset. Okay. I personally feel that we love the word sudden onset. Actually, it's not good. It kind of misleading us. The keyword will be the abrupt onset. That would be like I must say aortic dissection is like a subarachnoid hemorrhage of the torso. Okay, the abrupt onset. And the third one will be the radiation of the pain. This particular chest pain will have the radiation to the back and the belly. So the number one, the 3 question of pain. Number 2, the like I said, the subarachnoid hemorrhage of the torso. So it will come with the abrupt onset. Number 3, any chest pain, like a colicky pain, required any opiates or any narcotic, so you should heighten up our suspicious. So meaning this is could be a catastrophic of aortic dissection. Number four, the pain if you have a patient with migratory pain, you are being lucky actually, because that is have a higher likelihood, like a 7.6% of developing of aortic dissection. And final pain pills will be, this pain can be intermittent, meaning that it can start on and off, come and goes, because if we don't control, it might dissect further and stop and dissect until the towards the extent of the aorta.
Yeah, that's great, Dr. Zul. Have you encountered any cases with symptoms that don't really match textbook?
Yeah, I do have an encounter like a chest pain and then the radiating to the chest pain plus leg pain. So there's a principle of the concept of what we call the chest pain plus symptoms. Okay. So any chest pain, you should ask any associated symptoms that can, because it can dissect into the iliac artery number one. And if the patient presented with example like right upper arm weakness, you should ask the patient whether do you have any chest pain prior to that. So that is the one plus chest pain. So this is, you need to go backward and asking, do you have any chest pain? That could be the trigger. And you need to be like say the high index of suspicious. We don't really screen everyone, but if there's a factor, the major factor will be hypertension. 70% will have possibility of having aortic dissection, and also connective tissue disease, example like a muffin and the Danlos syndrome.
Yeah, because I've seen a case where the patient could not pinpoint where the pain was.
Yeah.
And because aortic dissection, the pain depends on where the location where the tearing happens. So in my case, the patient had aortic dissection all along the aorta thoracic down to the abdomen.
That's another important, where if you have a pain above the diaphragm and lower the diaphragm, two side, that is your jackpot that you should think of aortic dissection.
I see. Okay.
Okay. So any other ways that maybe like diagnostic imaging they can help?
Okay, we go to the basic first. I think the chest radiograph. Okay, if you look into the literature, there's dozen of signs of aortic dissection in chest radiograph. But I just want to highlight two that really specific towards the aortic dissection. Okay, mind you, 33%, like one third, will have a normal mediastinum. Okay, so you can miss. Okay, if meaning that normal mediastinum doesn't roll up aortic dissection. So what are the two radiograph that can suggest? Number one, loss of aortic knob. If you cannot see, or if you have an obliterated aortic knob, so you should think of aortic dissection. Number two, calcium sign. Calcium sign meaning those in the elderly, they will have this calcified aorta. So you can see double aortic knob. So you can measure anything more than 1 centimeter is highly suggestive of aortic dissection. Other than that, pleural effusion, you have a globular heart, that not really specific towards aortic dissection. So we just mainly these two findings. So that's a radiograph. For blood, we please don't rely so much on the D-dimer. D-dimer is not really helpful in diagnosing the aortic dissection. And 1/4 of the patient might have this troponin raise. So we're not sure whether this is ACS or aortic dissection. So again, go back to your history and physical examination.
Okay, so Dr. Zul, moving on from the symptoms, so going into physical examination, are there any specific signs that very reliable to rule in or rule out in the dissection?
Yeah, definitely. There's a few sign that we can pick up from our patient that's suggestive of aortic dissection. Number one, that when we look into our patient, we need to identify whether our patient is a muffinoid. Mind you, any age 40 and below that are developing aortic dissection, 50% of them is muffin syndrome. So how does muffin looks like? It's very tall, lanky, very thin person, and you can say very also long fingers. So number one, so you look into that. Number two, you try to hard to listen. Okay, I know that in reality that to pick up a diastolic murmur is very difficult, but if you're able to pick up a diastolic murmurs, a new diastolic murmurs in a patient, that would be a high index of suspicion of maybe it could be a IT dissection. And the final one will be the feeling of the pulse deficit. So pulse deficit, I mean, not many condition that can cause a pulse deficit, and one of it will be the IT dissection.
I mean the radial delay,
Yeah.
radiofemoral delay, yeah. Although I think the radial delay is present only in about 15% of aortic dissection.
It depends where it dissect.
Yes,
Yeah.
as well.
Definitely.
Dr. Zul, next is after picking up aortic dissection, so can you just elaborate on the management principles?
Okay, all right. For us in emergency department, number one that we need to address the pain, because patient will presented with a severe abrupt tearing pain. Pain score might up to 10 out of 10. So I think our job is to address the pain by giving opioid. Right? Some they give like a lot of opioid that even they call it like fentanylize. So meaning you give a lot of opioid because that is very important that we want to reduce this sympathetic stimulation for this patient because it might further dissect the aorta. Number two, they need to control the heart rate. Okay, our aim will be like aim towards 60 beats per minute. So what are the agent that very useful will be like esmolol, right? And also labetalol, which we can use it. And number three, we need to control the blood pressure. Our systolic blood pressure should aim down to 110 millimeter mercury. The best agent is still labetalol because labetalol can control, bring down the heart rate and also the blood pressure. I think that's the three principle of managing. Of course, next we call our counterpart in vascular or general surgery to help to fix the dissecting aorta.
Yeah. And how, in your experience, how is the collaboration between emergency department and our other colleagues from radiology, surgical department, speeding up?
If we have this suspicious from the history and physical examination plus the radiograph, chest radiograph, they are really helpful to facilitate the CT angio, and of course the vascular, and it depends on what type of IT dissection. That would be very helpful to fix it early, because once they dissect into the coronary or the pericardium, it can cause a cardiac tamponade. That could be, we already missed the boat. So I think it's quite the team effort is good. When our job is to identify and they're going to fix it later.
Yeah, I think once radiology is convinced about our the possibility of it being a dissection, usually they're quite helpful. In fact, I also have a personal experience where it was again a young girl, 20-something years old, muffinoid. She knows that she has muffin. She came into us with epigastric pain, which is rather, definitely not the typical presentation. And upon assessment, she didn't have radial delay. She had this very weird kyphoscoliosis kind of anatomy. And the good thing, again, I'm a proponent of ultrasound. So the good thing is that we can use ultrasound. We can actually pick up the fact that she did have actually something which looked suspicious. To be honest, this happened when I was very junior in my practice. And when I put the probe there, this does look suspicious. And when we talked to the radiology, when they heard that we could actually see something rather weird on the ultrasound. They were very helpful, and in the end, she did turn out to have dissection, and she did actually dissect into the coronary. So on table, she had to do on table bypass. Unfortunately, she succumbed, but that journey was definitely important in terms of identifying it and addressing it early. So that
I
was
would like to echo what Dr. Khadijah mentioned, the role of point of care ultrasound in identifying the aortic dissection.
No pun intended.
Yeah.
Cool.
Yeah. So I think when you put the probe, I mean, you can do echo, number one, to look for the aortic root dilatation, but in the abdomen, whenever you find the intimal flap, that is the what we call it, the
pinching feeling,
yeah,
basically.
the jackpot
Yep.
to diagnose the aortic dissection. So you can see how this intimal flap is like a retinal detachment. So that is very unusual. We shouldn't have this intimal flap in our aorta. So you know that there's a true and false lumen, and that would be the good. We can let our radiology colleague that we need the gold standard of CT and angiogram.
Yeah, I think that's the purpose of having education like this. We want to increase awareness
Yep.
and the level of knowledge among ourselves in emergency medicine fraternity, because aortic dissection is something that will not present according to textbooks always, and this sometimes we have issues in convincing our colleagues in other department, because our patient may not have the typical symptoms and signs, not typical X-ray finding, and we may not find the intimal flap on ultrasound because it depends on where the tear is.
That is true.
Yeah. So I've had experience where my patient is the same patient I was talking about, where we referred to the department, and they just examined the patient and documented there's no radio delay, and therefore they just documented as aortic dissection unlikely. X-ray, there was not really mediastinum widening so much, but the patient just didn't look right.
Yeah.
So sometimes you just go down to gut feeling. Yeah.
This out of proportion kind of a pain.
Yes.
Yeah. And the patient usually looks a bit restless.
She was restless. She had
Exactly.
Required any opioid given for the pain?
It wasn't a severe pain.
Okay.
The restlessness is usually the one which makes.
It can also have a painless aortic dissection.
Oh,
We don't go into that, but there's a literature mentioned that it might dissect slowly without feeling the pain. That's very small percentage.
We had one case actually in resus.
But how did we pick up the?
That's very difficult. Yeah.
Sure.
But that's what people always think of. It must be a very severe pain, but there's also a painless aortic dissection.
That's really difficult.
So thank you very much, Khadijah. So we'll take a short break before we go to the next topic with Dr. Khadijah. Okay, we are back.
That was ultra short.
Okay, Dr. Khadijah, we're gonna delve into your topic next.
Yep.
Now, you'll be talking about IVC ultrasound, particularly about the misuse of it. So it's very interesting.
Okay.
So before we go into that, Dr. Khadijah, can you just briefly tell us about the history of IVC ultrasound? How has it made into our clinical practice?
Okay, all right, sure. So basically the use of IVC in emergency medicine, it started off with the nephrologist. I mean, this was based on reading. To be honest, Dr. Aida did tell me that she wanted to ask about this, so I definitely went and went ahead and read about it. So basically, a kind of like the history came back from more of the nephrologist scanning their patients during dialysis, and they thought that theoretically speaking they would see a difference in terms of the IVC caliber at that time. This was way back in 1980s, and they did scans for the patients after they have achieved dry weight, and they tried to see whether any obviously when you dialyze, you'll be removing some fluids from the patient, and they thought that there would be difference in terms of the caliber of the IVC. But surprisingly, the studies actually showed that there wasn't much of a difference, to be honest. And that was kind of like surprising to me as well when I went to look into the literature, because to be honest, there was a point in our emergency life that we really clung onto the assessment of IVC, and we thought that this was the holy grail of assessment of fluid therapy for our patients. And anyway, subsequently, they did try to look into the changes of IVC in patients with trauma. And surprisingly, this trauma one was actually led by the ONG team, I think, and again, they didn't see much of significance in terms of the use of IVC, but people were still very interested in it. And there were a lot of other studies which were done in the late 80s up to the early 90s, and they actually still tried to see whether it could represent the right atrial pressure. So that was the intention of performing IVC scans. And if you remember from our early days as housemen and also junior MOs, we did do a lot of CVP measurements onto the patient, and we thought that CVP equals fluid status in patients, and we did have this magic number of keeping the patients within 8 to 10 centimeters of water, hoping that, you know, if you're less than 8, that you can push more fluids into you. If you're more than 12, you don't have to push in more fluids to you. And when we found, and when they talked about IVC, it was something that, you know, you don't have to put in a catheter into the patient, and you can scan the patient, and you thought that this was a really good option compared to actually putting in a lot of catheters into patients. And because of that, I think it really caught very well. The fact that we don't have to insert catheters, we can just take our ultrasound probe. Obviously, we were very comfortable with performing ultrasound. FAST has been very well established in us. We were starting to dabble into performing echocardiogram into our patients, but IVC was so accessible. You put the probe at the subxiphoid, you can just get your image very easily. You don't have to worry about echo windows and stuff like that. It's a very short procedure. You can actually see the IVC caliber. And why not? You know, we talk about the physiology behind it. It makes sense in a lot of ways. And they did talk about obviously the heart-lung interaction at that time, and the fact that when you inspire, you tend to have a difference in the intrathoracic pressure, and because of that you have a collapsed IVC and all that. So basically from there onwards, people really liked IVC. It was our pet in with regards to assessment of fluid therapy. But however, as the years go by, where we have started to question, and the question is not really about the IVC's ability to measure right atrial pressure, but it's rather the fact that, is right atrial pressure really the measure of a patient's fluid status? So that was the issue. Because when you think about it, there's a lot of things which can affect the right atrial pressure. And that's the reason why probably the central venous pressure wasn't even a good measure to begin with. So yes, probably IVC is kind of similar to CVP, but IVC and CVP are not really good measures of fluid status. That's what I can say about that. And the reason why I am a bit peeved with it is because whenever I go for rounds downstairs, attending to patients, and I ask my MOs, what is the patient's fluid status? The first thing that will come to their, when they answer me, it will be, oh, IVC is 2 cm, boss, no variability and stuff like that. And when I ask them, so what's the echo like? Or say, oh, cannot see the echo. Echo window very poor. So how do you know whether this huge IVC is truly due to fluid depletion, or if it's due to the right side of the heart not really functioning that well? So that's not fair for us to actually say that the patient's fluid status is full just purely based on one vessel. I know I'm jumping. Anything else you wanted to know? Sorry.
And talking about our practice on the floor, so IVC ultrasound has been used in many scenarios. So they've been using it for septic shock, for medical problems, or surgical trauma as well. So everywhere. So based on your finding, your reading, suggests that in all those clinical scenarios, IVC ultrasound is not the best measurement.
Yep, exactly. I would say that IVC is not the best measurement for fluid status. Okay, are we totally the bringing out IVC and disregarding it altogether. To be honest, during my training on critical care ultrasound, there were two situations where we will actually look into the IVC, and both of these are purely just to look into the right atrial pressure, not as an assessment of fluid status. So these two would be, one is the assessment for pulmonary embolism. I'm not going to go too deep into it, but they did talk about the rule of 60-60, and the first 60 is actually to look into the pressure from within the tricuspid valve, and it has to incorporate both the tricuspid regurg jet plus the right atrial pressure. The other time when you actually use the IVC is, what was it now? Sorry. What was the other one? So the second one is actually in the current use of what we call VEXAS. So VEXAS is the venous assessment to look into fluid tolerances. That's a huge topic. Obviously, I'm not going to touch about it, but I mean, I'm going to talk about it that much. But basically, these are the only two times when they actually look into the IVC, and it's purely again to say that, oh, look, the IVC now is congested. Let us look into the other veins as well to see whether other organs are congested as well, to suggest that truly this patient is, it can't tolerate much fluids anymore. So those are the only two points when actually we still measure the IVC. Otherwise, I would say that the value of IVC is only, to be honest, when it's really, really just a thin line. So maybe when the patient comes into you, so it's more of like it's a collection of all the other clinical assessments that we have. You see a patient, the patient comes in with a history of 3 days not tolerating orally that well, or being a bit sick, having high temperature. That's already that possibility of the patient being dry is there. You assess the patient, BP is probably borderline-ish, heart rate a bit tachycardic, and when you assess the mucous membrane, it looks a bit dry. And when you put the probe, it's really, you can't really see the IVC much. Well, yeah, okay, but it's just more of to confirm and to just say that yes, truly this patient is dry. Was there actually any added value in that? Probably not so. We've already seen everything with regards to the patient. Urine output is barely there, that kind of thing.
So our history, our physical examination, the
Yep.
traditional CRT, heart rate and all that,
Yep.
are as good as from
Exactly. Yeah. So yeah. And
So
the
we cannot replace our clinical
Oh,
assessment.
definitely not. The clinical assessment can never be replaced by anything, especially if you talk about IVC. And like we have mentioned just now, there's so many things which can affect specifically the right heart function, which can affect the IVC status, and hence. So pivoting to that, it means that if, for example, clinically the patient histories it should be dry, examination should be dry, and then suddenly when you put the IVC and you see the IVC huge, there must be something wrong. And you can't just say that, oh, the patient is fluid adequate just because the IVC looks huge. Because for all you know, maybe the patient has some issues with the right heart, copulmonale or whatever else, which can actually affect the IVC status as well. So that's the reason why I'm so, unhappy whenever my MOs actually report and say that they have measured IVC as the measure of the fluid therapy.
Dr. Khadijah, are there any ongoing research on new technologies or emerging techniques in assessing hemodynamic status?
Okay. That's a very tough question for me, Dr. Aida. I was only prepared for IVC. But anyway, I wouldn't say it's emerging much, but it's like, I would say that there are other modalities of assessing fluid status. And most of the time, the critical care world and the intensive care world, they look more into the cardiac output. And the cardiac output, either cardiac output per se or the stroke volume assessment. And there are a lot of ways to obviously measure these things. Having said that, it's still very difficult. We do talk about, for example, the velocity time integral of the aortic root, and looking specifically at the aortic root and what kind of, how much fluid actually comes out of the aortic root. That's probably the main measure that we're looking at nowadays. But do we actually really know whether that's a good surrogate? The way that we have always thought that IVC and CVP was a good surrogate of the patient's actual fluid status. So at the end of the day, if you look into a lot of literature, they can kind of suggest that it is possible but there's nothing beats a proper, again, clinical assessment together with the input and output charts, and also the way the biochemical reactions of the patient with regards to, multiple things, the base deficit, base excess, and the lactate levels, and the overall perfusion of the patient, which is a lot more important eventually when you actually assess the patient. So is there one magic tool which can actually dictate and tell us a patient's cardiac output or fluid status? I wouldn't say so. It's very dangerous, in fact, for us to actually depend on a particular tool. And at the end of the day, it's a holistic kind of assessment rather than just looking at one measure. So that's my take to it. Yeah.
Okay, thank you very much. Okay, Dr. Khadijah, this one statement of a take-home message from your topic.
Okay, so in conclusion, what I would say is that I'm not saying that we should totally, not assess the patient's IVC at all. But obviously, with anything what we do during clinical assessment, is that we have to have a collective assessment of the patient. You have to be holistic. You obviously have to assess the patients from history itself, and that's the main thing, which a lot of people actually do not want to delve further. That's our problem mainly. So we use a lot of tools, but we don't assess the patient's history that well. So history, physical examination is the same thing, to be honest. History, physical examination. If you want to take the probe, the first thing that you have to look at is actually to look at the patient's heart and know the repercussions of the heart onto the other vessels that you have. And obviously, the one which can directly be affected by the patient's right atrial pressure and right ventricular pressure is going to be inferior vena cava. And if you actually know how the heart looks like, then only you can actually read what is actually within the IVC. So that's my take-home message to that.
Okay, lovely. Thank you, Dr. Zul. Any take-home
Okay,
message
right.
from you?
So, okay, for my take-home message, for everyone, that first, always remember the big pain pulse. We need to go deeper on the characteristic of the pain. Number two, that for physical examination, always look for the suspicious looking murphanoid, feel for the pulse deficit, and listen for the new diastolic murmur. And do not rely so much on the blood investigation, and the usefulness of using focus in identifying aortic dissection. And lastly, our principal management of it, and treat the pain, control the blood pressure and the heart rate.
Fantastic. Okay, that's it for today, everyone. Thank you for listening, and hope to see you guys joining in the next episode.